So welcome, this is Dr. Charles Moak, and I'm going to talk about appropriate compression associated with venous disease. First I want to talk about something that is related to ulcerations and people that have really kind of ugly legs. And I saw that we were using some Una boots at some of the offices, and Una boots were invented over 100 years ago in Germany by a dermatologist, and we're still using them 10 years. You got a question when you're using something 100 years old, and it's big pain in the butt for the patient. They really don't work well. And I just have a paper here. This is just the front page, but this is from 2014 comparative study of 5 types of compression therapy in patients with venous leg ulcers. And they compared Una boots to every other type of compression. They found they were the least effective. The most effective was intermittent pneumatic compression. The second most effective were these inelastic compressions. These inelastic compression means they're not elastic, but they're compression. There's like little Velcro strips. We used to use these, and somehow we switched to Una boots. I don't know how. But these are actually 4 times more effective than the Una boots, and the patient can put them on at home. They have to keep coming in here for something that doesn't work. So knock it off with the Una boots, please. Those are ineffective. I know some patients in treatment now. We're going to stop and just put them in an inelastic if you think they need it. And do not withhold treatment while you're putting on Una boots or other dressings. We talked in the last section that the wounds will heal up twice as fast if you do treat the perforator veins. And I've heard, well, I want to get the swelling down. Treat them. Okay, this is a chronic condition, costs billions of dollars a year to manage their wounds. If you put them in the conservative management, they're going to just stay in it forever because the wound care center will gobble them up. So those patients need to be treated. Now there's the issue regarding conservative management before treating the veins, and Medicare even has a policy. When they have a policy on everything, they want you to use some kind of conservative management. 3-month trial of conservative therapy such as exercise, periodic leg elevation, weight loss, compressive therapy, avoidance of prolonged immobility where appropriate has failed. Now, we're not making the patients lose weight. We're not asking them that they walk. Obviously they walk. We're not making them do avoidance of prolonged immobility if it's not appropriate. Sometimes you do ask them to do that. And the stockings, what about the stockings? Well, people got all hung up on the stockings in the past couple of years. Says, well, Medicare says to do it. No, they say to do it if it's appropriate. Okay, and if you think it's appropriate to treat them with stockings, that's what you should do. So if we think it's appropriate to treat these patients with stockings, then we have to decide, are we following the standard care? This is the guidelines, clinical practice guidelines from the Society of Vascular Surgery in American Venous Forum, 2011. And they state, verbatim, number 9.2, we recommend against compression therapy as a primary treatment for symptomatic varicose veins in patients who are candidates for saphenous vein ablation, period. It is inappropriate to make these people wear stockings for 3 months when they don't work, okay? And when Medicare made these guidelines, they made it years ago for surgery, and we kind of fudge it into ablation. That might be appropriate for surgery. It's so much more invasive. But this is, have them avoid prolonged standing where appropriate. Have them lose weight where appropriate. Have them do compression therapy where appropriate. It's not appropriate. So we have a thing in our documentation that says, they tried conservative management where appropriate. If you think some specific thing is appropriate, let them do it. It might be a timing issue, but it's not necessary to make them wear stockings for 3 months because Medicare gave you an out. They said if it's appropriate, do it. Evidence came out and said it's not appropriate. Our college stands behind us saying it's not appropriate. Don't need to do it. So a big pain in the butt in our practice is the stockings, right? We got to put them on afterwards. We're having people doing all the weight walking. And sometimes we have to ask ourselves, how do we get there? Well, back in the 80s and 90s, we were doing surgical stripping and there was a lot of bleeding, so stockings were used. When the lasers came out, we thought we should use stockings. When we started doing sclerotherapy, we thought we should use stockings. Compression stockings prior to treatment. Some insurance companies require us to do it, and they're very specific. Very few of them. Most of them just require the patient to have done conservative management where appropriate. Some of them say that some insurance carriers, they say, well, have them wear compression stockings if we deny the treatment. But in general, unless there's some specific rules, it's not necessary to document that where appropriate you have them do conservative management. This is an interesting study, a systematic review of compression hosiery for uncomplicated varicose veins. They looked at 25 clinical studies, 25, and they found no evidence that treatment with compression altered the outcomes for varicose veins. Okay, so it does nothing. We have the guidelines from the American Venous Forum and Society of Vascular Surgery saying it is inappropriate to put them on stockings if you can treat them. Okay, so we're clearly being told, treat the patients, don't make them wait. So what about compression after? Should we be compressing them after? Well, when we started doing endovenous laser ablation, there was evidence that people that had, when we started doing endovenous laser ablation, those people that had been doing surgery and they moved over to ablation, so we started compressing them. And there was a study done on a laser called the 810 nanometer laser. And that was the first one that was out, 810 nanometer laser. Nanometer is the wavelength of the light. And it would have worked on the target for the 810 was red, so it was actually targeting the blood cells. And when it would burn the vein, it was actually poking little holes were occurring, so little explosions occurred in the saphenous vein. They had a lot of bruising and pain and discomfort. And stockings seemed to help them, so we put them on them. In this study done regarding using the 810, they found that the patients, if they wore stockings for 2 days afterwards, they had less discomfort in the week following the procedure. Okay, interesting. So we all started using stockings. When the newer lasers came out that attacked water instead of blood, 1320 and 470 and the radiofrequency device, and what these do is they heat the vein wall up. And we didn't see as much pain. In fact, the 810s hurt a lot, and I started using the 1320 Cool Touch. Didn't hurt as much. We started using radiofrequency, hurts even less. So what about the science on these? Do we need stockings? Okay, in this study, they followed patients they did a 4-year study, and they put one group of patients after doing radiofrequency in thigh high 30 to 40 for 7 days. And the other group, they gave them no compression. Okay, radiofrequency, 4-year study, 1 week of 30 to 40, and the other group had nothing. No difference in outcomes, none. They had the same amount of discomfort, same amount of success, made no difference. So this tells us radiofrequency is not necessary. Here's another study for laser, and they looked at randomized control studies. This is a systematic review, and they found that there was no evidence that stockings made any difference after procedures if you excluded the 810 nanometer. So if you're using this, stockings. We're not using it anymore. If we're doing the Cool Touch 1470 or the radiofrequency, stockings make no impact. So it's not necessary. You don't put the patient through all that unnecessary. You might put a bandage on them or something, but wearing those stockings are a pain in the butt. Some people might want them, they can use them, and they can go home with them because we're going to use them for MFT. We'll talk about that in a moment. And they can put them on if they're sore, but the radiofrequency causes so little pain and discomfort, it is an overkill. So now we'll talk about compression for MFTs, for sclerotherapy for MFTs. Now sclerotherapy is the sclerosing agent for the veins. And sometimes we refer to sclerotherapy for spider veins, but really that MFT is a form of sclerotherapy. There's been a few studies. I pulled one for each of these things. Here's a study where they randomized people after varicose vein MFT. 124 people randomized to 24 hours of compression, 60 people, and 5 days of compression, 60 people. So 60 of them got 24 hours of compression, and 60 of them got 5 days of compression. And what they found was that there was no difference between the two groups. Now, they didn't do a study with no compression, and my experience is that the patients do have discomfort if you don't compress them afterwards. So my suggestion is that we compress the patients with a thigh-high stocking for a day, and tell them after that they can take it off. If they're having soreness during the day, they can put them on daytime, but wearing them 24 hours around the clock is unnecessary. We kind of have this policy about the patient can't get up or anything with the stockings on. It's not really that much of it. That might be a little bit of overkill. So put the compression stockings on. They can take them off when they get sick of them or at 24 hours. If they're sick of them before then, they can take them off. Probably that night at bedtime, it's not necessary. And then afterwards, they can wear them during the day if they want to for comfort. After laser RF, not necessary. Bandage is fine. You can use them if you want to. After MFT, 1 day is probably good enough. What about for spider veins? So first off, there was a study in phlebology for French sclerotherapy and compression. Now, sclerotherapy was really popular in Europe before it came to America. And they really found that there was no consistency amongst the doctors on whether they used compression or not, and there was no consistency on whether or not the patients were compliant. And their summary was, we don't know. So an American study done is called Compression After Sclerotherapy for Telangiectasias, spider veins, and Reticular Leg Veins, a randomized controlled study. In this study, they had 2 different groups. Group 1, they put them in compression for 3 weeks rather than 2 weeks like ours. And group 2, they didn't put them in any compression. So these are for spider veins. Group 1, 3 weeks. Group 2, no compression. They found a little bit better results with compression. However, they had to treat 5 people with compression before one person got a slight increase in results. Okay, results are pretty close, but if they treated 5 people with compression, one of the 5 people would have gotten a little bit better results than without. So it's sort of an overkill thing, and I recommend we do for spider veins is tell people, you may benefit from compression, maybe don't use such a high compression, and it's probably not necessary. Maybe wear them for 24 hours, but if you want to have the best possible results, wear them for 2 weeks, maybe better, probably not. So really 80% of people will not benefit from it, 20% will. I would say probably for sclerotherapy, we don't need to use compression at all. We should just change that policy. So to have 4 people go over a big pain in the butt, so one person get a slight benefit is maybe not a good risk-benefit ratio, because compression is an interruption of quality of life. So thank you very much.